Lucas Hill is one of our incredible pharmacists at the Owen Clinic, our HIV clinic at UCSD. But everyone's in for a great treat today. Lucas is really such an incredible pharmacist and it works so well with our patients, but he's also really always on top of the literature. And I'm really glad he's going to be talking to us about new antiretrovirals today. And with that, I'll pass it on to Lucas. As usual, please put the questions or comments into the chat. Hopefully I'll have figured out what's going on with my computer, and I'll interrupt Lucas for clarifications, but we'll try to save some time for some dialogue at the end. Go ahead, Lucas. Sorry.
Great. Thanks, Jill. Hi, everybody. So I'm going to review some of the newer antiretrovirals. This topic idea was actually Jill's, and I think it's a good idea. And I'll look at both approved, but also most of the time is going to be spent reviewing pipeline drugs that are getting closer to approval. So I ended up with more slides than I anticipated. So hopefully I can get through everything. If not, of course, the slides will be available for review if you want. So let's get started. And like Jill said, please stop me with any questions if you have any. My disclosures, I'm on the Gilead Speaker Bureau. So I'll try and frame the new medications into a patient case, a real patient case that we have at Owen. And then we'll go over Phostensive, cabotegravir, rilpivirine, leronlimab, Islatuavir, and then lenacapavir at the end. So let's start with a case. This is a patient of Miley's that we have. He's a 54-year-old white male who was diagnosed with HIV in 1992, and his Cd4 count at diagnosis was 698. He has no other significant medical history. In terms of his HIV viral load history, he has really only ever one value since 1992 of being suppressed, once in 2007. Otherwise, he's been viremic the whole time. He's got a CD4 nadir of 3 in 2006. So this is his extensive ARV history. Hopefully you can see my pointer. I think you can. So in 1995, he started on a study with AZT and D4T, and then was on various studies over the years, has had a lot of exposure to Pranavir. He's got a couple periods of time where he was on Fusion, and then studies with some of the integrase inhibitors, elvitegravir. I was on raltegravir, also on dolutegravir. And then most recent history from basically March of 2016 to March of 2020, he was on a regimen of Odefsey with AZT, dolutegravir, and boosted darunavir. So these are his labs. So I just put in his basic CMP over here to show there's not much going on. He's got slightly elevated kidney function, mild CKD. But other than that, not much else to talk about. These are his viral load trends over time. So starting over here, the oldest to the newest. So you can see, like I mentioned, detectable viral load despite being on his medications. I don't know if we can say he's got perfect adherence, but he does take his medication. So this really mostly at this point isn't being driven by adherence, it's a resistance issue. And then his CD4 trends over time, which is really why we started working on interventions here, because of the decline in his CD4 count from 2017 to now, more recently in late 2019. So pretty consistently under 150 with single digit CD4%. So he's had a ton of resistance testing over time, especially because he's been in so many studies. And so I just am going to show you a few examples of what his resistance tests look like. So this is a PhenoGT from 2018. So if you're not too familiar with looking at these, let me just orient you real quick. So we have the names of the drugs over here, and then broken down by class. So NRTI, NNRTIs, INSTIs, and protease. Then we have what is considered the net assessment by monogram as to whether the drug is resistant or sensitive. They show what the cutoffs would be for the fold change in IC50 to determine if the drug is resistant or not, based on the phenotypic data. And then this is the actual fold change in IC50. And this is a graphical representation of that. And then they list also the mutations that he has. And then they individualize the determination of resistant or sensitive based on phenotype and genotype. So, I think the overall takeaway from this is it's bad. But I think a few things to look at from the NRTI class. The only drug that may have some activity for him is tenofovir. So it's got a 2.4-fold shift in IC50, making it partially sensitive. And of course, this is based off TDF, not necessarily TAF, which may have more activity than TDF in this situation. But other than that, he's got resistance to all the NNRTIs. You notice that the newest NNRTI, doravirine, isn't included in this report because it's from 2018, but I'll show you some data for that in a second for him. And then probably most concerning, or one of the most concerning issues, is that he's got max fold change to integrase inhibitors. So basically no activity from the integrase class, and then pretty much the same story for protease. So no activity from the protease inhibitors either. So pretty impressively, the darunavir has a 194-fold shift in activity, which makes it completely resistant. And he's got several major darunavir PI mutations. So this is his tropism this is from 2015, looking at whether Maraviroc would be an option. Unfortunately, he's got dual mix virus, so we can't use Maraviroc. And then this is a phenosense entry assay from 2015, basically looking at if Fusion is active. For him, it is. So other than the partial sensitivity to tenofovir, the only other active drug he has is Fusion, but he currently absolutely refuses to use Fusion again. He said that it just decreased his quality of life to an extent that he won't use it. It caused too much side effects in terms of injection site reactions and nodules in his abdomen and things like that. So although we tried to push for Fusion's off the board for him. And so I mentioned that the previous resistance test didn't look at the phenotypic data for doravirine. So we did rerun a pheno-GT without integrase, because we already know what he has for integrase, just to look at doravirine sensitivity, which is right here. And he's also got, doravirine is not active either for him. So obviously very few options. So the question is, can we come up with a treatment regimen? And this leads us to really a discussion about one of the newest medications that was just approved, which is Phostensive. I decided to take the data out that I had in here for Trogarzo because it isn't new. It's been out since 2018, and it's been reviewed before, and we have enough other stuff to go over. So. But I did want to talk about Phostensive. I went over this data with the people at Owen maybe a month ago. So I apologize if you've heard this before, but I think it's important to go over in this situation again. So the brand name of Phostensive is Rukobia, and it's a first-in-class attachment inhibitor. I think it was approved in June. And it's a prodrug, so as it shows on the right, basically it gets converted from Phostensive to the active drug Temsivir, which is then absorbed from the GI into the plasma. Phostensive or Temsivir is active against R5, NX4, and dual tropic virus, and hasn't shown any cross resistance to other antiretrovirals. So essentially, it's a new mechanism of action. So the indications, the FDA indication is treatment of HIV in heavily treatment-experienced adults with multi-drug resistant HIV failing their current antiretroviral regimen due to resistance, tolerance, or safety considerations. And the dosing is it's an extended release tablet, 600 milligrams taken twice a day. So I like this slide because I think that it shows it's good at showing the different mechanisms of our different entry inhibitors. Just a few years ago we only had 2. Now we have 4 different entry inhibitors. What it shows over here on the left is Phostensive. So Phostensive binds directly to GP120 and prevents attachment of HIV to the Cd4 receptor. So it is an attachment inhibitor. It doesn't allow attachment to the cell. You can compare this to the post-attachment inhibition. So this is ibalizumab or Trogarzo that I had mentioned, which is the IV infusion. And that's a monoclonal antibody against the domain 2, the Cd4 receptor, which basically prevents entry once attachment happens. We all know about Maraviroc, which inhibits binding to the CCR5 co-receptor. And then you have Fusion or enfuvirtide, which is a large protein that basically gets in the way and prevents membrane fusion after attachment. So all prevent entry, but in different ways. So this is the pharmacologic profile for Phostensive. So as I mentioned, it's dosed 600 milligrams twice a day. Like I said, it's a prodrug. Absorption-wise, the prodrug has good solubility but poor permeability, which is why then it gets converted to the active drug, which has poor solubility but good permeability. Bioavailability is increased with a high-fat meal, but it doesn't have to be taken with food. It can be administered with or without food. Relatively high protein binding, eliminated mostly 50% in the urine, and it does undergo some metabolism. So mild 3A4 substrate, and then also a drug transporter substrate, so PGP and BCRP. And then we'll talk a little bit more about drug interactions and if it affects any other medications. And it doesn't require dose adjustments in renal or hepatic impairment. And then there's the issue of QT prolongation. So it did show, it did prolong QT, but only at super therapeutic doses. So basically 4 times what the actual dose is. So at the standard dose of 600 milligrams twice a day, there's not really expected to be any issues with QT prolongation. In terms of a summary of drug interactions, so Temsivir as a victim, it is potentially impacted by inhibitors or inducers of 3A4 as well as the drug transporters, so BCRP or P-glycoprotein. The concern is really only going to be with strong inducers of those transporters. So it's not considered clinically relevant interactions with strong inhibitors or moderate inducers. In terms of Temsivir as a perpetrator, it doesn't inhibit any of the major CYP enzymes. It doesn't induce any of the major CYPs. It doesn't seem to affect UGT, which is important mostly for integrase inhibitors. It doesn't inhibit PGP. The only thing it may affect is substrates that are substrates of some of the other transporters like OATP, BCRP, and MATE, and I'll talk about what that means for drug interactions. So I think the key to remember is the drugs to avoid are the potent inducers like carbamazepine, phenytoin, St. John's wort, and then rifampin. It's okay to use with rifabutin, just not rifampin. There's also an interaction with ethinyl estradiol. It increases the concentration, so they have a dosage limit of that. It's expected to increase concentrations of the statins, so using lower doses of statins may be appropriate. And then a few interactions with some of the hepatitis C protease inhibitors, because it can increase their concentrations, which can increase risk of potential liver toxicity. But there should be no problem using it with any of the antiretrovirals. No issues with opioid substitution therapy. We talked about the ethinyl estradiol issue, and then we talked about the QT prolongation. So they do caution about co-administering it with other drugs that may prolong QT. And then I think also thinking about if you give it with a potent inhibitor of some of the drug transporters, then you might get higher concentrations of Temsivir, which could potentially increase the risk for QT prolongation. So I wanted to go over the BRIGHT study, which is the phase 3 randomized placebo-controlled double-blind trial that led to the approval. So there's basically two different cohorts for this. There's the randomized cohort, which were highly treatment experienced patients who were failing their current regimen, so they had to have a viral load of greater than 400. But have one or two classes of ART remaining with at least one fully active drug, but unable to construct a viable regimen from remaining agents. And that group was randomized to an 8-day period of Phostensive versus placebo, plus their failing regimen, and then at day 9, changed to Phostensive plus an optimized background regimen. And then there was also a non-randomized cohort, which was basically kind of like a compassionate use scenario for people who were failing with an elevated viral load and had 0 active remaining agents available. And they were just put on Phostensive plus optimized background regimen. So the breakdown of the participants, mostly male, 80% male, 70% white. The mean viral load was about 4.5 log, and the median T cell count was 80. So obviously a more advanced population with uncontrolled HIV. And as much as 30% of the participants had less than 20 T cells at entry, with 86% with an AIDS history. So this shows what agents were included in the optimized background regimen. So in the randomized cohort, the majority of people were on dolutegravir, of which most were on BID dolutegravir. The green shows if it was active, and the yellow if it was not fully active. So most had dolutegravir that was active, and then followed by darunavir, although less with active darunavir. And then the non-randomized cohort, as you'd expect based on what was the entry criteria, basically didn't have fully active agents. Most were on dolutegravir and darunavir and tenofovir. And then there were 15 patients who were put on Trogarzo or ibalizumab, also in the non-randomized cohort. So this was the primary endpoint, which was the mean change in HIV viral load from day 1 to day 8. So you can see Phostensive group had a significantly higher decrease in change in HIV viral load at day 8. So 65% of the participants had a half a log reduction in viral load, and 46% had a 1 log reduction at day 8. So this looks at those that had suppressed viral load through 96 weeks, and this is the snapshot of the intent to treat analysis. So this is the randomized cohort. So you see at 96 weeks, there were 60% that achieved a suppressed viral load. And then 10% basically didn't have virologic data at that time. And then in the non-randomized cohort, which is the more difficult to treat cohort, roughly 40% achieved undetectable viral load at 96 weeks. And then of those 15 people who were on ibalizumab, the response rate at 96 weeks was 33%. So 5 out of the 15 achieved an undetectable viral load. But this is the observed analysis, so it looks a little bit better when you just look at those virologic outcomes. And this breaks it down based on those that achieved less than 400, less than 200, and less than 40. So it looks a little bit better. So at 96 weeks, close to 90%, 80% got to less than 40. And then in the non-randomized cohort, about 60% were able to get to less than 40 at week 96. And then this is from the package insert, which kind of breaks down response rates based on different groups from the BRIGHT study. So if we look on this column here, which is the week 96 data, basically those that had higher viral loads did worse, as well as those that had lower T cells did worse, which would be expected. the difference really was whether there was at least one active agent in the background regimen. So if there was at least one active drug, 65% were able to get to less than 40 versus only 20% if there were no active agents. And then they looked at use of dolutegravir and darunavir as a component of the background regimen. And so if dolutegravir was active or included, that seemed to result in the best outcomes. So, 60% roughly getting to less than 40 when they were on dolutegravir. And then this looks at the change in CD4 count over time. So on the left here is the mean change in T cell count in the randomized cohort in blue and the non-randomized cohort in yellow. So between 100 to 200 increase in T cells over 96 weeks. And then I think what's impressive is that there were those that had less than 20 T cells had a mean increase of 240 cells over 96 weeks. So a good T cell response in these advanced patients. In terms of tolerability and safety, not too much stands out. So these are the drug-related adverse events. If we look at the adverse events that led to discontinuation, there were only a few: abdominal pain, 3 with QT prolongation, and then non-cardiac chest pain and hepatic failure. And then the typical side effects: nausea, diarrhea, headache. So not too much that stands out. And then these are the laboratory abnormalities. So there were some patients who had elevated AST, ALT, but these were really almost all in patients who had hepatitis B and or hepatitis C co-infection. So in those that had HBV or HCV, they saw grade 3 or 4 elevations in 14% versus only 2 to 3% in those without viral hepatitis. There were also about 20 patients with elevated creatinine, and basically what it said was that these were in people with pre-existing issues related to renal disease, and there's not an expectation that there's a relationship between Temsivir and changes in renal function. And then I just wanted to wrap up on Phostensive, looking at some of the resistance data. So as I said, it does have a unique resistance profile. And there hasn't been any cross-resistance identified with the other classes. And most viruses do have good sensitivity to Temsivir. However, there is a broad range of in vitro susceptibility related to the diversity in the GP120 region. And so there's been identification of 4 amino acid substitutions that may affect susceptibility to Temsivir. So 375, 426, 434, and the 475. So this shows that in the study, 40 to 45% of the patients actually had one of these 4 mutations at baseline. Also this over here shows the full change in sensitivity to Temsivir. So roughly 90% maintained less than 100-fold change in Temsivir activity, with a small percentage having a greater amount than that. But the question is, do these baseline substitutions predict outcomes? And I think that the answer is that no, they don't really predict response. So this looked at the change in viral load from day 1 to day 8 based on some of these factors. So if patients did have one of those baseline polymorphisms, there was a smaller number of participants, or they had a smaller change in viral load at day 8. So even though there was a smaller change in viral load, there were still 55% of those people who had a viral load reduction of greater than half a log. Also looking at those that had a greater than 100-fold change at baseline in Temsivir activity, they also had less of a viral load response, but still 38% had a greater than half a log decline in viral load. And then HIV subtype mostly did not predict response. Although you see maybe there's these patients with type A, subtype A, but the numbers were very small. And I think most importantly is that this looks at those that had protocol-defined virologic failure versus those that didn't, based on the substitutions and the fold change at baseline to Phostensive sensitivity. And basically, it doesn't seem that anything pans out as predicting the likelihood of virologic failure based on either the sensitivity or the presence of these mutations. Maybe this over here, where there's a higher number of failures in the group with higher fold change in this cohort, but it's a small number of patients. So at this point, there's not any recommendations to do any baseline testing. We don't even have the commercial availability to sequence the region to know what polymorphisms are at baseline, but still something to be aware of. So if we go back to the case, so this is what happened over time with his viral load. So we decided to simplify all of his oral drugs to just Simtuza, and then add Trogarzo, right? So which is the every 2 week monoclonal antibody infusion, and then add Phostensive to his regimen. So we actually accessed Phostensive early before it was approved via their expanded access option for him. And so he started on March 5th of 2020 on his new regimen, and you can see his viral load response over time. So most recently, he just got labs drawn last week, and he was undetectable, which is really, really great. And then you can see his T-cell response. Right here is where he started his new regimen, and he's actually had a nice gradual increase in his Cd4 count over time as well. So he's a really challenging case that so far looks like things have been working out well for him with this new regimen, which really highlights these situations where having an agent with new mechanism of action, how important it is for patients like this. So I'll pause there before I move on to some of the unapproved agents, if anyone has any questions.
Hey, Lucas, can you hear me?
Yeah.
So this is Adam Zweig speaking from AHF. Viv has sort of speculated that the pre-attachment function of Phostensive may be the reason why there's such a robust CD4 cell increase, because it limits the immune system activation that might occur at attachment or post-attachment. Have you seen anything about that?
Yeah, I've heard the same thing, but I can't say I've seen anything specific to support it one way or the other. This was our first patient on Phostensive, and so far we only have one other with another probably about to start, but so we'll kind of see what happens in our patients. But yes, I've heard the same thing. The other thing that I've also heard is that based on the mechanism, it seems in the studies that over time, more and more patients may actually get to undetectable. So if you looked at the curve over the number of weeks, how many people became undetectable, it actually continued to increase as you went to 96 weeks. And so even though there may be some patients who don't quite get there early on, they may actually achieve undetectable viral loads later. But yeah, it's a good point.
Thanks.
Okay, so I wanted to kind of move on to some of the drugs in the pipeline. I think you'll see the trends for most of these is either novel modes of administration and less frequent dosing, or brand new mechanisms of action that likely will have activity in patients with multi-drug resistance. And so this is brand name is Cabenuva. This is the long-acting injectables, cabotegravir with rilpivirine. So just to review the data, this is data from IAS in 2019, and this is a pooled summary of the Atlas and Flare studies at week 48. So just a reminder that the Atlas study was in patients who were suppressed on ART, and they were randomized to either continue their current oral ART or switch to a 4-week lead-in with oral CAB rilpivirine, followed by once-a-month injections of CAB rilpivirine. And then there was the FLAIR study, which was a similar design, but this was in ART naive patients. And they were initially for the first 20 weeks, started on Triamec, and then after 21 weeks, randomized to either stay on Triamec or again do the oral lead-in with CAB rilpivirine, followed by the once-a-month injections. And so looking at the baseline characteristics, generally young, mostly male, so 70% male, 70% white. Their median T cell count was in the 600s, so well-controlled HIV with a small percentage having Hep C co-infection. So these are the results at 48, the combined results at 48 weeks. And so you can see that there was non-inferiority between being on the once-a-month CAB rilpivirine injections versus being on remaining on their oral ART, so roughly 93, 94% suppression at 48 weeks. And then this breaks it down based on different subgroups. Nothing stands out as having a shift one way or the other in terms of better outcomes based on subgroups. In terms of safety, the safety results were fairly similar between the oral regimen and the injectable regimen. For the common side effects for the injectables, nasopharyngitis, headache, upper respiratory tract infections, diarrhea were the most common. They also did look at some psych-related adverse events, given probably that rilpivirine is included in the regimen, and it's been shown in the past that maybe rilpivirine has some psychiatric side effects, but there were no differences between the two groups really in anxiety, depression, or suicidal ideation. And this is the data for the injection site reactions. So as you can see over time, injection site reactions decreased. The first injection within the first month, the first couple injections, almost 70% have an injection site reaction, which is characterized mostly as pain. But then that declines over time. The majority of the injection site reactions were grade 1 or 2, so 99%, and most of them, 88%, resolved within 7 days. And this is the patient satisfaction. So despite the injection site reactions, the green is the injection group and the purple is the oral group. So more people said they preferred to be on the injections. And so there was high patient satisfaction. So although it hurts, I think that a lot of people see the benefit of not taking oral pills every day. And then I think what's interesting is the resistance results. So there were 3 confirmed virologic failures in the Atlas study and 3 in the FLAIR study. Interestingly, all of them were subtype A, mostly type A1 from Russia. Here they report the baseline resistance. So 2 of them had baseline mutations that could affect rilpivirine sensitivity. They didn't report any with baseline integrase resistance. This leaves out the L74I mutation because it's not considered to be a significant mutation, but what we know is L74I is more common in the subtype A patients. And so 5 out of the 6 did have L74I at baseline. And then this shows what happens after failure. So all the patients had mutations conferring rilpivirine resistance. 4 out of the 6 had integrase mutations that affect cabotegravir. They show that dolutegravir should still have activity in these patients, though. We'll talk more about this. But they looked more specifically at having a baseline L74I. So what they saw, of course, is that it is more common in subtype A. So 86% of those with subtype A had an L74I, with the majority of the patients that had the mutation coming from Russia. But when they broke down the response rates based on the presence of that mutation at baseline, there was no difference between the 2 groups. So it doesn't seem like having that mutation predicts the response to the injectable therapy. So then this is data from CROI of this year, which was the 96-week data from FLAIR. So the top box here is the response rate at 96 weeks. And so pretty similar. There was non-inferiority between staying on Triumeq basically versus going on the once-a-month injection. There were no additional virologic failures between week 48 and week 96 in the injection group. There were 2 participants who withdrew from the injectable arm between week 48 and 96 due to injection site reactions. And then this is also from CROI of this year, which was the result of the Atlas 2M study. So this is now using the injections every 2 months instead of every month. And so they took, what they did was they took patients from the Atlas study and would roll them into randomization to either receive once-a-month injections versus once every 2-month injections. Or if they were on the standard of care arm, they would do the oral lead-in and then get randomized again to either once a month or once every 2-month injections. The dosing for the regimen is different depending on how frequent the injections are. So if it's once a month, they get 400 milligrams of CAB and 600 milligrams of rilpivirine. If it's every 2 months, they get 600 milligrams of CAB and 900 milligrams of rilpivirine. So these are the results. So they looked at how many had a viral load greater than 50 copies at week 48. It was similar between the 2 arms. So 5 in the 4-week arm and 9 in the 8-week arm. There were 8 confirmed virologic failures in the 8-week arm, so 1.5%, and 2 confirmed virologic failures in the 4-week arm, so 0.4%. And so if we look at the failures, so the top here is those that were confirmed failures in the 8 weeks versus those that failed in the 4-week group. So again, you see some patients with the subtype A, but there were also non-subtype A's that failed as well in this study. Looking at I think it's interesting looking at the resistance mutation. So in those that failed, they went back and looked at the proviral DNA samples, and several, 1, 2, 3, 4, 5 out of the 8 had baseline mutations against rilpivirine that probably contributed to their failure. So I think what's interesting is, for example, the E138A, this is a polymorphism, so it may not even be acquired mutation that, if you look it up on Stanford, is predicted to have unknown activity against, or unknown effects on rilpivirine sensitivity, but I think it's now shown up in both the 1 month and 2 month studies, and I think it begs the question of is it worthwhile getting archive resistance testing in almost all these patients before we switch them to the injectable regimen. And then also, of course, you have patients who have a history of exposure to NNRTIs, who may have these mutations at baseline. And so it's going to be really important to think about who we switch to CAB rilpivirine injections. And then again, if most did not have integrase mutations at baseline, and then if they failed, 1, 2, 3, 4, 5 out of the 8 did develop integrase inhibitor resistance mutations. And then this just summarizes the injection site reactions between the every 8 and every 4-week arm. I don't think there's anything that stands out as being too different. 1% in the 8-week arm and 2% in the 4-week arm withdrew from the study due to injection site reactions. So to summarize CAB rilpivirine, so it is going to be the first injectable non-oral ART regimen, which of course has many benefits related to potentially adherence, stigma, pill fatigue. Technically, it's going to be directly observed therapy. In general, it's going to have limited drug interactions. It seems to be pretty well tolerated. But I think there's a lot of questions about who the right patient is for this regimen. I think we've talked about this. Everyone's probably talked about this a lot. And I think the concern mainly comes from those patients who are not that great at coming into the clinic. So that raises some questions about resistance, and then of course the PK tail. I didn't show the data. There's data from CROI of this year that specifically looked at what the PK tail looks like in people who discontinued their regimens during the study. Injectable CAB has a half-life of around 6 weeks, and rilpivirine a half-life of around 30 weeks. So, there's fairly significant drug concentrations for CAB up to, at least 6 months in most people, and rilpivirine 12 months in most people. So there's going to have to be a plan for switching to oral ART if they end up stopping the injections. I think there's still some questions about use in women and pregnancy. Again, there was some data at CROI looking at what the PK looks like in women who become pregnant, which seems to mirror women who are not pregnant. I think they had reported on 3 fetal outcomes, which were fine in those who were on the injectable therapy, but definitely something that we have to think about in a broader sense. And then logistical challenges, of course, of figuring out insurance and how to do the injections in clinic and all of that. And then I didn't mention it, but of course, CAB is coming for PrEP. Everyone, I think, has probably heard about the data comparing CAB to Truvada in PrEP, and that the CAB group was superior for the injectable CAB for PrEP. So that's definitely something that's coming.
Lucas, but before you move on, and I realize it's 1:45, so I don't know how much you have left. And maybe we can talk about it at the end, because you brought up logistical issues, and I actually thought you were going to talk about the bigger logistical issues of a drug that was supposed to come on the market or be available in January, and now we're mid-September. Maybe we can talk about that at the end, because I think that's been really challenging for patients who were eager to get started on this, and sort of what does that mean in the confidence of the drug. But we can talk about at the end. I want you to finish what you're doing here.
Right, of course. And I didn't mention that, we expect approval of CAB rilpivirine already, and that's been delayed. So the hope is that it'll be available, I think, early 2021. But yeah, we can talk about that. I decided to add this a little bit late, leronlimab, which is Pro-140, but I added it because we've had several patients at Owen who have been on this study. It was, there were sites in San Diego. So Pro-140 is a humanized monoclonal antibody that binds to CCR5. And so it inhibits CCR5 mediated entry without really affecting the immune activity that's related to CCR5. And it's shown to be effective again in multi-drug resistant HIV as well as wild type. And it's also been shown to be effective in virus that has resistance to Maraviroc, right? Because you can develop resistance to Maraviroc even with having an R5 tropic virus. And it's a once weekly sub-Q injection. So there's a study with this drug in treatment experienced patients. So they included patients with R5 virus who had a greater than 400 copies at baseline for viral load. And they had to be treatment experienced with resistance to at least one drug within 3 classes, or within 2 classes with limited treatment options. They excluded, of course, X4 dual mixed virus, as well as some other exclusion criteria. So this is the data that was presented. This is the study design. So they were randomized for 1 week to receive a 350 milligram injection of Pro-140 versus placebo. And then after 1 week, changed to an optimized background regimen plus weekly Pro-140. The only data they've reported so far, even though this is from 2018, is the viral load change after 1 week. 73% were male in the study, 50% white. Their mean viral load was 21,000 copies and a mean Cd4 count of 298. So there was a significant change in viral load reduction between the placebo group and the Pro-140 group after 1 week. They also reported it was well tolerated without any discontinuations and low rates of injection site reactions. I think the only thing I could find is the data for those that were rolled into their optimized background regimen, that there was data so far for 9 patients out to, I guess, 25 weeks. And all 9 were suppressed, but I haven't really seen anything beyond that. And then The interesting thing, I think, and this is the study that our patients were enrolling in, is that it's being looked at for single agent maintenance therapy. So they were enrolling patients with R5 tropic virus who were suppressed and switched them to leronlimab monotherapy for 48 weeks. They included patients who were on ART for at least 48 weeks, were R5 tropic, had no detectable viral loads for the previous 24 weeks, a nadir CD4 greater than 200, and their CD4 had to be greater than 350 for the previous 24 weeks. So this was looking at 3 different dosages, 350, 525, and 700. And this was data from CROI of last year. But I think the challenge is that it's incomplete data. There's ongoing patients on the study in all 3 groups. So I spent a lot of time trying to figure out how to interpret the data they presented, and I think they don't even have ends. And so I can't tell, how many patients we're looking at here in each group. Their interpretation was that the higher dose group showed good outcomes with low rates of virologic failure, but I think that's hard to say because there's very few patients. And so I think it's interesting agent, and it's an interesting kind of scenario what's happening with the drug. I think they actually at the end of 2019 submitted their application to the FDA for approval. And the FDA came back asking for more information, which they said they would be able to provide without doing studies, and that they expected a PDUFA date to be announced by July of this year. And there's just been nothing since then about it. So I don't know what's going to happen. Some of you, or a lot of you, may know that this is actually being investigated for COVID, which may have something to do with it. And there's been studies that I guess have shown positive outcomes in patients with COVID for this agent. And then also being studied for breast cancer and NASH. So they're looking at multiple indications for the monoclonal antibody. So we'll see what happens. But I know we had patients who stopped their ART and went on this monotherapy study. Some had good outcomes, some broke through. I know, and they actually had an arm where they would increase the dose if they had breakthrough. So we'll see. And this is the side effect report outcomes. But again, I think the reasons that the side effects are so different in the 700 milligram group is because there's just not that many patients that got very far in the study. So it's hard to interpret. So moving on to Islatuavir, we have just 2 more to cover that I think I can finish in the next few minutes. So Islatuavir is a novel mechanism of action. It's an NRTTI, so nucleoside reverse transcriptase translocation inhibitor. And so it prevents translocation of reverse transcriptase and also delayed chain termination in the sense that if translocation happens, it also prevents nucleotide incorporation going forward. And so this is the structure that lends to the activity of Islatuavir. So it has this hydroxyl group, which actually is missing in the NRTIs, but included in Islatuavir, which enhances phosphorylation of the NRTI, increasing antiviral activity. It has this ethinyl group here, which causes steric issues, steric crowding. So it prevents translocation and also prevents the addition of further nucleotides because of steric issues. And then it has a fluoro group, which prevents degradation by adenosine deaminase. So this drug has intracellular half-life of between 78 and 128 hours. And also, I didn't show the data, but there's in vitro evidence that it's active against NRTI-resistant variants. And so that reference is down here on the bottom if you want to look at it. The data I'm going to show is from IAS 2019, which is the phase 2 dose ranging study that is using Islatuavir as 2-drug therapy with doravirine, which is the NNRTI. So part 1 was dose ranging using Islatuavir, doravirine with 3TC. And then if they were able to achieve suppression at 24 weeks with that regimen, they could roll into the 2-drug therapy option. So this just shows baseline characteristics, 92% male. Median CD4 count was 456. and 78% had less than 100,000 copies at baseline. And this is the outcomes through week 48. So with the 2-drug regimen at the different dosages compared to, this is Delstrigo, basically, doravirine 3-TC and TDF. So a standard 3-drug regimen. And you can see the outcomes are similar. There's about 30 people in each group. So far it looks like good similar outcomes to the 3-drug regimen. This shows the people who had protocol-defined virologic failure, but all the participants that did have defined virologic failure had confirmatory repeat RNA levels that were less than 80 copies, so no one met criteria for resistance testing in this group. Looking at the adverse events, no deaths, 1 serious drug-related adverse event that resulted in discontinuation. It was prolongation QT in someone with congenital long QT syndrome, and that was in the triple therapy group. There were 2 participants in the higher dose Islatuavir group that stopped due to an AE, diarrhea, nausea, vomiting, and HBV reactivation. And there was really no dose-related adverse events, differences in adverse events. These are the most common AEs, so diarrhea, nausea, bronchitis, nasopharyngitis, similar things to what we see in some of the other studies. And then what was reported at CROI this year was metabolic outcomes. So I won't spend too much time on this because it's a relatively small group of patients, but they did look at weight change at 48 weeks between the 3-drug therapy group and the Islatuavir combined group. So this is percent weight change. So this is the combined Islatuavir group versus the 3-drug therapy group. That includes TDF, which tends to cause some weight loss. The absolute weight change in the Islatuavir groups at week 48 was roughly 4 kilos in the 2 groups here and 0.7 kilos in the higher dose group, and then about 2 kilos in the triple therapy group. They also looked at changes in bone mineral density. So they saw less changes in bone mineral density in the tenofovir-free group in the hip and similar in the spine. And then cholesterol was pretty similar between the groups. And it was large confidence intervals. And then I'll just mention that this is agents being looked at for PrEP. So this is once a week dosing in 16 macaques that prevented infection. So maybe a more long-acting PrEP option. And then this is data using an implant of Islatuavir. This is in human data that basically shows that the concentrations remain above target for 12 months with this implant. And it was well tolerated in general. So there were adverse events, but nothing that was severe. And then just to wrap up, this is the capsid inhibitor, lenacapavir. Capsid's involved in the life cycle throughout basically the entire life cycle. And lenacapavir inhibits multiple steps of the process, including nuclear entry, HIV assembly, and capsid formation. So this is some data from HIV patients that were given the capsid inhibitor. So multiple doses, 6 people in each group. They were followed for 10 days and then rolled into being on Biktarvy. And we see good viral load responses after 10 days. So mostly dose proportional with a range of anywhere from 1 to 2 log reduction over 10 days. They looked at the PK data to develop what the dosing strategy will be for the phase 2-3 studies. And they looked at up to 900 milligrams sub-Q dosing of the capsid inhibitor. And basically came up with this dosing regimen for the phase 2-3 studies because it takes a while for it to get up to the desired concentrations. There's going to need to be an oral loading period where they're taking 600 milligram dose day 1 and day 2, and then day 8, and then start every 6-month sub-Q injection of 900 milligrams every 6 months. So there's 2 studies coming with the capsid inhibitor, Capella, which is a placebo-controlled study with the capsid inhibitor added onto a failing regimen in heavily treatment-experienced patients. And then there's also Calibrate, which is going to be a phase 2 randomized open-label active controlled study in treatment-naive patients, and they'll be comparing lenacapavir with TAF or lenacapavir with BIC, and then also having control arms of Biktarvy and lenacapavir with FTC TAF. So those are some studies coming. Other time questions, that's my son giving everybody a fist bump for the day. Yeah, and I just want to say thank you to my colleagues in industry who really gave me most of these slides and the data, so I appreciate it. So thank you.
Lucas, that was so great, and what a cute way to end your talk. I could use a fist bump this morning. We just have a couple of minutes. The chat was actually very quiet. If anyone wants to unmute themselves, make a comment, or ask Lucas any questions or relate to the group.
Hi, Lucas, Robert. 2 questions. One, just based on what what we know so far about leronlimab, how do you feel about the, ability for, that to work as monotherapy? And then I guess it sort of leads to the second question. Jill mentioned logistics, and, where we as a clinic might see all this going for, our difficult population that misses appointments, et cetera, how, our visits might look, and maybe they're just coming to see you guys every 2 months, et cetera, et cetera. So your thoughts?
Yeah, I think it's a loaded question that we could talk about for a while. One, with Pro 140, I'm hesitant a little bit about the data and its use as monotherapy. But I mean, we'll see. If we could see more data, maybe we could make a better determination. But I'm not optimistic necessarily. The question of logistics with these long-acting injectables, I think, of course, we're looking at drugs that have different options, right? Some, caropivirine is going to be in clinic injections versus some of these other agents we're talking about, if they're sub-Q, might be able to be done at home. But, I think we can take an example from the long-acting injectables that we do in clinic right now, right? Which is mostly Sublocade and Vivitrol, where they have to come in every month for their injections. It's not easy to manage. We have only maybe, 20 to 30 patients on these therapies, and they're sometimes hard to track down. Granted, the patient population is difficult, but they're hard to track down, and it takes a lot of logistics to make sure the insurance covers the drug at the right time and the drug's present in the clinic when the patient walks in for their injection. So we here at Owen, the pharmacy team's already put together a little bit of a work process for when the injectables get approved and how we're going to go about doing it. The thing to remember too, I think, is for caropivirine is that they're going to have to enroll in a program through the drug company to get the oral lead-in, and then the oral lead-in gets sent, and then you have to have a loading dose of the injection and then a maintenance dose of the injection. So yeah, to your point, there's going to be a lot to figure out for that, especially if we want to scale it up.
Yeah, Robert, we've had some great discussions around this, and I think we'll look forward to more of them. We started them, again, back in the end of 2019 when we thought the drug was coming, which is a whole other issue now that, again, I sort of alluded to, and we don't have time to get into it now. But again, I think a lot of us really thought this was a big, this might be the saving grace for patients that really did have a lot of trouble coming into the clinic. But this just came up for me, a patient I saw on Wednesday who I haven't seen in 9 months. He would not be the person I'd want to put this on if I didn't, if it was really going to be challenging to see him every month, maybe every 2 months ultimately. But that's, a really difficult aspect of this. And I think it will mean a lot more community engagement and working with organizations where where our patients maybe go regularly, and that's going to take a lot of coordination and planning to do. But it's definitely a great option if it will work. And I think we talked about trying it in some of our more stable patients to begin with, where the pill fatigue was a bigger issue, to just see how that goes and then try to build it out from there. But
I agree. It's tempting to want to use it in people with adherence issues, but that may not be the right group initially to use it if they're not going to come in, but mostly for the resistance related issues. So.
All right. Well, Lucas, this was so great. You're getting lots of great comments in the chat. And actually, just at the end, Nettie just added, I'd say about 5% of my patients I can reliably trust to come in on time every month. And that we actually missed, maybe I'm not sure. Maybe she means of the ones where she's considering this, where that would work for. And yeah, it's definitely going to be a challenge. So, well, fortunately, we have a lot. Sorry, go ahead, Lucas.
No, I was just going to say, there is some PK stuff related to the fact that there will be some flexibility in terms of how often they have to come in, and it won't necessarily be the end of the world if they're late, especially once they get established. But yes, to her point, you do have to have some reliability that the patient's going to show up.
And I just wrote back for my misunderstanding or not interpreting that well. Okay, well, everyone, thank you. Lucas, this was great. I think a great review of some drugs that we will be starting to use and see a little bit more. So thank you so much.